Hello, good evening, everyone. I welcome you all to another session of Bharati Ruma Clinics. Today, we have a very special guest faculty, Dr. Tanmayee Bichile. Dr. Tanmayee Bichile is a rheumatologist at Allegheny Health Network in Pittsburgh, Pennsylvania. She completed her medical school in 2008 from our very own Krishna Institute of Medical Sciences, Karad, Maharashtra. Then she went on to complete an internal medicine residency from St. Francis Hospital, Evanston, Illinois in 2013. She has completed a lupus and rheumatology fellowship from the Johns Hopkins School of Medicine, Baltimore, Maryland in 2016. She is a clinician but also involved in medical education at Allegheny Health Network, where she has co-developed a lupus curriculum for the fellowship program. She has served as a board member and patient advocate for Pittsburgh Arthritis Foundation. She is currently serving as the president for Pennsylvania Rheumatology Society. She is the local chapter leader for the AVID, Association of Women in Rheumatology. She has an interest in lupus with published work on clinical research, review articles, and textbook chapters. She is currently serving as a work group member on ACR Collaborative Initiatives Lupus Virtual Provider Series Work Group. A very warm welcome to you, Dr. Tanmayee. It was very nice of you to accept our invitation. So today our topic is diffuse alveolar hemorrhage in SLE. We have two cases which were a little difficult to treat. So the flow will be our postgraduate students who are doing the DM clinical immunology and rheumatology with us. Both are in the third year now. They will be presenting two cases, the patients which we have managed in our institution. And then we can interact with them during the case presentation, following which we shall have a short talk by Dr. Tanmayee Bichile. Dr. Varsha Bhatt, you're there? Yeah, so
Yes,
Dr.
ma'am. I'm there.
My colleague.
Hi, good evening, everyone.
Yeah. So
Good evening, Tanmayee.
Yeah. So
Hi,
she's
nice to be
faculty
here
at
with you all.
Bharati Vidyapeeth. And our students, Dr. Shri, you will start presenting?
Yes, ma'am.
Yeah, okay. Okay.
So, good evening to one and all here. So, we'll start this discussion with case one. So, case one is a 23-year-old Mrs. X, who's a housewife, who studied BCom and is a mother of one child who's 4 months old. I would like to start the history from 2020 as a present condition is a continuation of the previous illness. So, her history starts in September 2020, where she had history of rash, left knee pain, for which she had consulted a family physician, and she was advised to take some topical creams for the rash and HCQS for the left knee pain. In the course of a month, she developed oral ulcers and rash. She developed oral ulcers and rash over the face, worsened with new lesions over the palm, upper limb, lower limb, and soles. This was followed by a history of cough with blood and sputum associated with shortness of breath. She was evaluated for the same and was found to have ANA of 4 plus homogeneous with dsDNA positivity and ENA showing U1RNP bar SM, Rho, and SM. And her basic lab showed CBC of HB of 6.7 with total counts of 2,900, platelet 60,000. Her DCT was negative, complements were low, and urine protein was normal. Chest X-ray done showed bilateral fluffy opacities. She was diagnosed as SLE with DH, musculoskeletal, and hematological features, and she was given IV methylprednisolone pulse therapy followed by oral 1 mg per kg with mycophenolate mofetil 2 grams per day. So till April 2021, she was asymptomatic. And in April 2021, she had worsening of a small and large joint pain. So at this time, her mycophenolate mofetil was changed to methotrexate by her family physician. After that, she was asymptomatic till January 2022. She discontinued all the medications by herself as she was planning for the pregnancy. And in March 2022, she had conceived and had joint pains for which she started on Ayurvedic medications. She was asymptomatic throughout the pregnancy. In October 2022, she delivered a male child, which was little preterm. but the baby was healthy and was doing well. And after almost a year, she had presented to us in March 2023 with complaints of joint pain of involving the small joints of hand, knee, ankle for the past 2 weeks, with fever, rash over the face, arms, and feet, which was similar to her previous episode, with oral ulcers for 1 week. She also had complaints of hemoptysis with shortness of breath for 1 week. On examination, her heart rate was 120 with saturation of 88% at room air with pallor present. On respiratory system, bilateral lower lip lobe crepes were present. And also she had a drop in HB of 5.6, total leukocyte counts of 1,900 and platelets of 56,000. Her complements were again low and DCT was negative this time and urine routine was normal. A CT chest was done which showed bilateral fluffy opacities with ground glassing as shown in this image. So we knew that she was already a known case of systemic lupus erythematosus, and the current issue was a recurrent DAH, polyarthritis, hematological, and mucocutaneous feature. We had started a treatment with IV injection methylprednisolone, 500 milligram for 5 days, and this was followed by injection cyclophosphamide by NIH protocol. But unfortunately, she was lost to follow-up after 3 doses of cyclophosphamide. So our questions are the choice of immunosuppression in acute setting of DAH, cyclophosphamide versus rituximab, and also ANA positivity in ANCA vasculitis. Will there be any difference in management?
So this is a really complex case, and I do have a couple of questions. Do you mind going back to the first slide?
Yes, ma'am.
Yeah.
Yes.
So it looks like she is a really young, woman who is postpartum and is presenting with rather, aggressive onset of lupus.
Yes, ma'am.
Do you know if she was postpartum in the September, October 2020 timeframe?
Ma'am, that time she was not conceived. Actually, this postpartum was after when she had presented to us. In 2020 to 2022, she was managed outside.
So during the first presentation, it sounds like she had DAH as an initial manifestation. Do we know if she had any renal involvement at this time?
No, ma'am. Actually, urine protein was normal and creatinine was normal. So she did not have any renal involvement at that time.
Okay. And the treatment for the DAH at this time, the first initial presentation was the methylprednisolone and MMF. Is
Yes,
that right?
yes, ma'am.
She did not get any cyclophosphamide during this presentation.
Yes, ma'am. She did not receive cyclophosphamide.
Okay, okay. And then moving forward, it looks like there were gaps in care with loss of follow-up followed by a pregnancy.
Yes, ma'am.
And she's now presenting for the second time to you guys, or rather the first time to you guys, but with a second episode of DAH.
Yes, ma'am.
Okay. So for this this hospital admission, I'm guessing she was hospitalized for the second time with you guys. Did she have any renal involvement at this time?
No, ma'am. She again had a normal urine routine and a normal creatinine. She did not have a renal involvement in this episode also.
Okay. And then do we know if a bronchoscopy with BAL was done?
We had actually offered her, like we wanted to do the bronchoscopy, but she did not consent for the procedure, any invasive procedures. So we had deferred in this case.
Okay. And do you know if she has any underlying symptoms concerning for any infection, or was an infection workup done?
For her, ma'am, actually, she did not have fever she had fever at presentation, and also there was desaturation. So initially we were thinking, could it be infection versus diffuse alveolar hemorrhage only? And
Mhm.
but the total counts was not elevated, and rather it was on the lower spectrum, like 1900 with lymphopenia. So that was going in more favor of uh,
Mhm.
infection. And
Mm.
we had done a procal levels, which was
Uh-huh.
normal. So
Okay,
the chance that she would have had infection was quite low on the list.
sure. Now, is she taking her background medications when she came to you, like her hydroxychloroquine, or
No,
she had stopped even that?
completely stopped after her postpartum. She had completely stopped even the Ayurvedic medication which she was taking. So,
And what Ayurvedic medicine was she on? Do we know?
no, ma'am, she did not have the medicines or the prescription. So, we are not
Okay.
aware of what medicines she was.
Yeah, so I think all these are really good points and questions. When I give my presentation, hopefully it will help to answer some of the questions you're bringing up. I would suggest, if it's okay with all of you, to keep going, and then we can come back to the specific questions after the presentation, because hopefully the presentation will help to answer some of the questions you have now.
Yeah, that's fine, I think. Yeah.
Go ahead with the next case then, ma'am.
Yeah, sure.
Yeah.
Share my screen then. So coming to the second case. So she was a 26-year-old lady who was a known hypothyroid, but it was well controlled on thyroxine 100 microgram. And she was admitted with us for a period of 5 days from November 26 to December 1st, 2023. At that time, she was presented to internal medicine with complaints of anasarca, nephrotic range proteinuria with microscopic hematuria, Coombs positive autoimmune hemolytic anemia, and polycirrhosis. So based on this, a multi-system involvement was suspected and an ANA-IF was ordered, which showed a 4+ co-spectral pattern as we can see here. And ANA blot showed RNP bar SM positivity along with SM, Rho52, dsDNA and histones. In view of suspected renal involvement, we also did a dsDNA by ELISA, which was positive for high titers of 734 units, and the complements were also low. So based on all this, she was diagnosed as a case of systemic lupus erythematosus. And then she underwent a renal biopsy to typify the type of class of lupus nephritis she had. And while awaiting the biopsy report and after the renal biopsy, she was started on pulse methylprednisolone of 500 mg for 3 consecutive days, followed by 1 mg per kg glucocorticoids. And then the further immunosuppressive therapy was to be decided based on the class of the renal biopsy. And a biopsy showed, as we can see here, a class 4 presentic lupus nephritis with an activity score of 15/24 and a chronicity score of 3 out of 12. So then she was due for follow-up with the biopsy report with us. When in the early morning of 7th, that is almost 6 days after her discharge, she presented to the EMD with tachycardia, tachypnea, accelerated hypertension and hypoxia. And this was her X-ray presentation, where we can see there is infiltration in the bilateral lung fields, most likely suggestive of an ARDS. And in view of her desaturation and dropping sensorium, she was intubated. And the labs done that time showed a rapidly progressing renal failure, where her creatinine at discharge was 1.9, had risen to 3.2 mg per deciliter. And chest X-ray showed bilateral fluffy shadows, and also there was anuria and hypertensive crisis. So based on this, the patient's antihypertensives were escalated. A diuretic trial was given, following the failure of which she was initiated on hemodialysis and was being managed in the intensive care unit. Now, further on evaluation, we found that she had a hemoglobin drop of almost 3 grams from 9.3 to 6.6, and with a further increase in ventilatory support. That's when we suspected a diffuse alveolar hemorrhage, and then we ordered an HRCT thorax, and also a bronchoalveolar lavage was done in this case. Now, here again, HRCT is showing a diffuse ground glassing opacities of the bilateral lung fields, and this BAL showed hemosiderin-laden macrophages in the smear. So then she was, for the DAH part, she was started on plasma exchange, and she underwent 3 cycles of plex, which were spaced out with SLED, which she was undergoing. And the last cycle was on 14th of December. That is almost around 6 days we took to complete the 3 cycles of plex. Now, patient general condition after the plex showed improvement, and she was gradually weaned off the ventilator. And she was again managed with pulse steroids followed by 2 mg per kg glucocorticoid. And in view of her renal involvement, which was around class 4 lupus, along with the DH, we decided to give her cyclophosphamide and NIH protocol, which is 750 mg per meter square. And for her body weight and after renal adjustment, it came to around 900 mg. But even after cyclophosphamide, she persisted, and even after high dose steroid, she persisted to have DH, where we again saw persistent HB fall from 10.7 to 8.1. And since there was ongoing hemoptysis and continued oxygen requirement, we decided to change her regimen of cyclophosphamide from NIH to Cyclops protocol, where we gave her 15 mg per kg renal adjusted dose. And this was the X-ray which was taken almost, I think, around 15 days after the initial episode, and it was still showing presence of DH. So the second dose of cyclophosphamide, as per the Cyclops protocol, was given on 28th of December. Now she completed around total 5 doses of cyclophosphamide, and she was doing quite well until Feb 2024. So this was from December to February. Now, in March 24, on routine follow-up to the OPD for the next dose, she was found to have again a drop in HB with further again shoot up of ESR and CRP of more than 140 and 115 respectively. Now, again, at this point of time, she still had ongoing autoimmune. As a part of looking for the reason for the drop in HB, we thought of ruling out the hemolytic anemia part, where DCT, though was positive, indirect Coombs test was negative, and there were no obvious evidences of hemolysis like a raised LDH or hyperbilirubinemia. And she had Krebs in the right lower lobe, and chest X-ray, though minimal, showed some amount of opacities in the right lower zone. So giving the benefit of doubt and suspecting ongoing DH, we decided to change her immunosuppression from cyclophosphamide to rituximab. And she received the first dose of rituximab on 9th of March, followed by a second dose on 2nd of April. There was a slight delay of more than 15 days because she had one intercurrent UTI during that period. Now, so this was the case, and now currently the patient is doing well after 2 doses of rituximab. She has been on follow-up with us last week, where she currently has her HB is well maintained. She doesn't have any oxygen requirement right now, and she's also on minimal dose of glucocorticoid, I think around 15 mg of prednisolone. So this was the case timeline, where on November 23, she was diagnosed as SLE, and in December 23, she presented with DH, followed by cyclophosphamide of total of 5 doses she completed. And then in Feb 24, she presented with another ongoing episode where we changed over her immunosuppression to rituximab. So the questions we would like to discuss, or the queries what we had in this case was, what was the role of plasma exchange, or what is the role of plasma exchange in DH, which is associated with lupus? Then the routinely used Cyclops protocol in ANCA vasculitis, what is the role of it in lupus-associated DH? And the pros and cons of sequential immunosuppression with cyclophosphamide followed by rituximab.
Okay. Yeah, I think most of these questions will hopefully be answered again by the end of the talk for you. But I do have a couple of questions. So the reason her cyclophosphamide was not completed, was it because of the UTI and the anemia, or was it because of persistence of DAH?
Persistence of DH was the main reason, ma'am. Persistence of DH and persistent elevated inflammatory markers despite completing 5 doses of cyclophosphamide. That's when we decided that maybe the disease activity is not coming under control with cyclo, and then we decided to change over to rituximab.
And so, the reason to stop Plex after 3 sessions, what was the reasoning behind that?
At that time, she did not have any persistent, that was almost on 14th of December, ma'am. So after that, she did not have any continuation of the DH, but she again started having it almost, I think, around 5 to 6 days after stopping it. So that's when on 23rd of December around, we decided to change over, give the next dose of cyclophosphamide, but as a Cyclops protocol. Like we predated.
So this patient was intubated, right?
But after the Plex, she got extubated, ma'am.
So did she get extubated after 3 sessions of Plex?
Yes,
okay. Okay. So she got extubated and then her Plex was stopped.
Yes, almost on 1 or 2 days here back and forth, but yes, she did get extubated and then the Plex was stopped.
And when she had that drop in hemoglobin with the rise in the inflammatory markers, was there any infection workup pursued?
Yes, ma'am, we had done procalcitonin and we looked for local signs of infection. There was no focus. Blood cultures were all negative. Urine cultures, which had once we had one UTI episode that had settled. This was after that. After a course of antibiotic, this happened. Like this was in March 24. And sometime in Feb, while on cyclophosphamide, she did have an UTI episode, which was treated almost with 15 days of IV antibiotics. And the cultures came negative. And after that, this HB drop persisted. That's when we decided to change over to rituximab.
So do you know if any viral studies like CMV, EBV, HSV, if any of those were checked?
We did only the cultures, and culture had grown E. coli in her case in the urine and blood both, ma'am.
And I'm assuming she didn't have infective endocarditis at that time.
We have done an echocardiogram, which is normal. There are no vegetations on the echocardiogram.
Okay. Okay. So do we have another case or are these just the two cases?
Okay,
Okay.
it's fine here. There's just two cases. So I
Yeah,
think
so
you can start with your talk and then maybe we can
mhm.
discuss after that. I request everybody to put their questions in the chat box or they can ask directly after the talk is over. Yeah, go ahead.
Okay. So I was trying to, I don't know if you guys can see my slides. Probably not.
Please stop sharing your slides. Yeah.
Sharing my screen.
Okay.
Yeah,
Can
now
you
you
see
can
it
see,
now?
but go to the slideshow. Yeah.
Okay, so, these are really complex lupus cases, and, this is not unusual, unfortunately, in lupus. Young women who are of childbearing age can have very aggressive disease as presentation, and we know that lupus does tend to disproportionately affect women of color with very aggressive disease. So, because we have two cases of DAH, but one case of RPGN with DAH, which is very consistent with pulmonary renal syndrome, I thought I will focus a little bit on RPGN as well, and then go over to the DAH part. So our second case had rapidly progressive glomerulonephritis with crescentic class 4 lupus nephritis, along with diffuse alveolar hemorrhage. And the first patient is also with recurrent diffuse alveolar hemorrhage. So RPGN is a glomerular disease that is manifested by a progressive loss of renal function that tends to occur rapidly, usually within a short period of time. So it's typically over a few days, weeks, and at times over a few months. Now, RPGN can affect any age group, including children. And when we think about RPGN, I would really encourage you to look at the kidney biopsy and think about, is there presence of crescents? And if there is presence of crescents, how much crescentic involvement is going on? So when we talk about crescentic and non-crescentic RPGN, non-crescentic RPGN is usually less than 10% of crescents on biopsy. So the pathologist will usually not report any crescents when they see less than 10% crescents, and will label the RPGN or label the GN on pathology as non-crescentic. But if they see presence of crescents, based on how much crescents are going on, it will get labeled as crescentic. And I think there's a little bit of a gray area between 10 to 50% crescents in biopsies, but usually all pathologists are going to report crescentic GN for biopsies which show at least 50% or more crescents. So why is it important to look and know about crescents on kidney biopsy? I know we have some fellows and students and residents here, so can somebody chime in? I just want to pick brains here and see if we can have an interactive discussion.
Yeah. Deepti, Shri.
To know mainly about the type of the nephritis, ma'am, like crescentic, we can see how severe is the disease or how what further immunosuppressive therapy to plan. Because if crescentic, then we will prefer high-dose cyclophosphamide over an MMF, usually in lupus nephritis case. So that is one. And then second, we can also probably try to know the etiology of the underlying nephritis also.
I think all those are great points. So knowing the underlying diagnosis and choose a choice of immunosuppression. Any other reason to know about crescents? Okay. I think those are good answers. You know, we definitely want to know what's driving the RPGN and, you know, what medication to go with. But the degree of crescents can also help us predict response to treatment.
Yeah, there are
So
two answers on the chat box. Poor prognosis needs aggressive treatment. And another student is a fibrous or cellular.
Yes. So, you know, and I think that will help us to predict response to treatment. So if you have somebody who has RPGN that has circumferential crescents and it's involving over 80% of glomeruli, it will probably, you know, is giving us clues that this patient is not going to respond to aggressive treatment and may even progress to renal failure. And, you know, usually patients with less than 50% of crescents, especially the ones that are non-circumferential, can usually respond to treatment and also go into remission. So along with the diagnosis and the choice of treatment, I think the prognosis and some prediction is also, you know, of help when we are thinking about crescents. So when we're talking about crescents, do we know what is a crescent? What do you call a crescent on a pathology slide?
Yeah, anybody can answer. Akanksha, Shreen.
And if you don't know the answer, it's okay. I think that's the purpose of this.
Yeah, but if you know, you can answer.
Okay, so, you know, so crescents are basically, you know, two or more layers of proliferating cells, you know, which are seen in the Bowman space. And that's the hallmark of inflammatory GN, and it's a histopathologic marker of severe glomerular injury. So this is a really nice picture from UpToDate, which, you know, I included here. It shows a hypercellular circumferential. You can definitely see it's more than two layers. It's a crescent because it's shaped as a crescent around the glomerulus, and it's basically compressing the glomerular tuft in the center and closing the capillary lumens. So you can see this is a couple of really nice. This is circumferential. This is probably a little non-circumferential, but that's basically what a crescent is on biopsy. So RPGN has different etiologies. From a rheumatology standpoint, I would like you to think about RPGN as, you know, either from an anti-GBM disease or immune complex mediated like lupus or IgA vasculitis, mixed cryoglobulinemia, or post-streptococcal GN, and then posse-immune necrotizing crescentic GN from ANCA positive or ANCA negative vasculitis, and then idiopathic RPGN. So the typical clinical presentation is nephritic syndrome with hypertension, oliguria, anuria, hematuria, pyuria, and proteinuria, with the presence of RBC cause that's seen in GN. And then the hallmark is rapidly worsening creatinine. The treatment is usually aggressive because this is an aggressive disease, with pulse solimedrol followed by 1 milligram kilogram prednisone, immunosuppression choice based on the underlying disease, as well as Plex can be utilized. So coming to diffuse alveolar hemorrhage, you know, as the name suggests, it's bleeding into the alveolar space. And it's usually because of the disruption of the alveolar capillary basement membrane from various disease processes. And there are three basic pathologic mechanisms for DAH, which have been described. Number one is pulmonary capillaritis. Number two is bland pulmonary hemorrhage and diffuse alveolar damage. So pulmonary capillaritis is an inflammatory capillaritis where there is neutrophilic infiltration of the alveolar septa, leading to the loss of the capillary structure that leads to spilling of RBCs in the alveolar space and interstitium. So pulmonary capillaritis is the underlying pathophysiologic mechanism in most rheumatic diseases, as we can see here. the vasculitis, including ANCA-vasculitis, Behçet's, cryoglobulins, IgA, HSP, or, anti-GBM disease, lupus, APS, rheumatoid arthritis, and so on and so forth. Pulmonary capillaritis can also cause DAH in patients who are on certain drugs like hydralazine, carbimazole, PTU. TNF-alpha, interestingly, is also reported. And any patient with stem cell transplant, infective endocarditis, or leptospirosis in the Indian setting can get pulmonary capillaritis and DAH. So this is a slide which shows, I don't know if you can see my cursor, but this is the alveolar space, and this is the blue is the septa. So you can see that the septa is quite edematous, it's stretched, and there are some areas of necrosis seen where the loss of architecture is noted. But more importantly, the septa is infiltrated by neutrophils, which are degrading and pycnotic. So it tells us that the neutrophils are activated from whatever underlying etiology is that is causing an inflammatory change in the septum and leading to the alveolar capillary basement disruption followed by hemorrhage. Now, this is a slide which shows early capillaritis. You can see that the alveolar space is still pretty intact, but there is infiltration of the septa with neutrophils. So what is bland hemorrhage? So as opposed to capillaritis, bland hemorrhage is when there is no inflammation in the septum. So there is no infiltration of the neutrophils. There is no disruption of the alveolar capillary basement membrane. Now, this can be seen in lupus and anti-GBM, but I would assume capillaritis is the more predominant process in our diseases. Bland hemorrhage, I would like you to think first about other diseases like anticoagulation, thrombocytopenias from TTP, HUS, ITP, mitral stenosis, idiopathic pulmonary hemosiderosis, and promyelocytic leukemia. I would like you to think about celiac disease when you see somebody with idiopathic pulmonary hemosiderosis. It's always important to check for celiac in these patients. Now, this is a slide that shows, some, you can see the hemorrhage in the alveolar space, but you can see that the alveolar capillary basement membrane is, pretty intact. It's, it's not infiltrated by neutrophils. These are type 2 epithelial cell lines, which are hyperplastic, but there's no disruption of the basement membrane with edema or neutrophilic infiltration. And then the third process for DAH is diffuse alveolar damage. So diffuse alveolar damage is very characteristic for any patient presenting with acute respiratory distress syndrome, where there is edema of the alveolar septa, but formation of hyaline membranes that line the spaces. So DAD can be seen in our patients, especially lupus, polymyositis. Any cause of infection can lead to diffuse alveolar damage. Important to remember recreational drugs like cocaine and amphetamines that can lead to this, and then radiation therapy. So this is a slide for showing the diffuse alveolar damage. So you can see there is edema of the alveolar septum there, but the hyaline membrane is this arrow over here, which is lining the alveolar space, and you can see the presence of hemorrhage. So anytime you have a patient with diffuse alveolar hemorrhage, I'll always try to think about what could be the underlying pathophysiology. Is it capillaritis? Is it bland hemorrhage? Or is it diffuse alveolar damage? And, taking a good history, physical exam, getting initial evaluation with a infectious autoimmune workup, looking for drugs, I think would help you to differentiate some of the pathology. Now, unless you do a lung biopsy, you're not going to be able to see the biopsy changes on the lungs that are consistent with these processes. But I will say that, in this day and age, we almost never need to do a lung biopsy, we can figure out the underlying driver of the DAH from our history-taking labs and the bronchoalveolar lavage. Now coming to DAH in lupus. Thankfully, DAH in lupus is uncommon, but it can be potentially fatal. So in one study, they found that 3.7% of their lupus-related hospital admissions were secondary to DAH over a 10-year period. Now, this is a US data from the 1990s. And then the same study found that 0.7% of those patients had recurrent DAH. So thankfully, DAH rate was less than 5%, and recurrence of DAH rate was less than 1% over a 10-year period in this patient population. This is a study from the 90s. So I don't know most recent US data, but I'm predicting with our treatments, this is potentially even lower. Now, this is a Korean study which showed that 1.3% of their lupus hospital admissions over a 16-year period was from DAH. A Chinese study showed the same percentage of hospital admissions, but over a 5-year time period. Now, interestingly, autopsies of these patients show focal collections of red blood cells with more diffuse involvement, which makes me wonder if our patients who have bad lupus and die have some subclinical DAH going on as well. Now, SLE DAH can be fatal with high mortality, but thankfully, survival trends over the years have shown an improvement from 25% survival in the 1980s to 67% survival in 2010s. Now, there are poor prognostic factors for DAH and lupus, including mechanical ventilation, renal failure, and coexisting infection. So you can see that your second patient, had 2 of these poor prognostic factors, which I wonder if they were a contributing factor to recurrence. Now, DAH in lupus is twice as common in women as compared to men. It's most commonly seen in patients who have a known history of lupus, but can be an initial presentation as well. And on an average, DAH tends to occur 35 months after the diagnosis of lupus. Now, risk factors for DAH are high disease activity and interestingly active class 3, class 4 lupus nephritis. So you can see that your second patient had both of these risk factors. So do the fellows or the residents know what the most common clinical presentation for DAH is?
Yeah, you can unmute and answer.
Desaturation, breathlessness, hypoxia, ma'am. May not be hemoptysis always.
Yeah, so dyspnea is the most common presentation. Hemoptysis is not. So any lupus patient presenting with acute dyspnea, along with acute lupus pneumonitis, DAH should be on the differential, even in the absence of hemoptysis. Do we know how frequently hemoptysis occurs in DAH?
Frequency, I'm not sure, ma'am. Maybe around 30 to 40%, ma'am.
So hemoptysis is present in only up to 2/3 of patients with DAH. And this is true not just for lupus, but even your ANCA vasculitis. So it's important to remember that up to 1/3 of patients with DAH will not present with hemoptysis. So the lack of hemoptysis does not automatically rule out DAH. And then hypoxia, and interestingly, fever can occur in up to 1/4 of patients with DAH. And we know that fever can be a presenting feature of lupus as well. So in terms of additional evaluation, you're going to check for labs, including CBC, CMP, to look for anemia, thrombocytopenia, renal involvement, UA with microscopy and protein to creatinine ratio to look for lupus nephritis, lupus activity labs, and then infection workup and coagulation studies. And I would add a UTOX as well here to look for other etiologies. In terms of radiographic studies, chest X-ray and HRCT to show diffuse airspace consolidation and ground glass opacities. And I always try to get a bronchoscopy with sequential bronchoalveolar lavage in these patients. So some more questions for the fellows. Do we know what sequential bronchoalveolar lavage is and how it is performed?
No, ma'am, not heard of it. A sequential valve.
Anybody else?
No, ma'am. Not here.
Okay. So, and do we know what is the characteristic bronchoscopy finding on BAL to confirm the DAH?
Usually we have a hemosiderin-laden macrophages in diffuse alveolar hemorrhage. And directly on the bronchoscopy, we will be able to see the bleeding and we'll be able to visualize the through the bronch.
Okay. And then do you know what clues on cytology? So I think you said the hemosiderin-laden macrophages, so that is good. So basically, sequential DAH is, where you take about 50 to 60 ml of sterile saline, and you are injecting that into the subsegmental bronchus, and sequentially you will see that the return is more bloody. So this is a patient who had sevoflurane-induced diffuse alveolar hemorrhage in the postoperative period. I really like these aliquots here. So you can see that there are 3 aliquots of sterile saline, and each one of them is progressively hemorrhagic. So that is very important to confirm DAH on bronchoscopy. That is the typical sign. And on cytology, like you already mentioned, it's hemosiderin-laden macrophages, which is seen on a Prussian blue stain. Now, sometimes patients don't have these, sequential hemorrhagic changes on the BAL. That's where the cytology with hemosiderin-laden macrophages can help. Now, hemosiderin-laden macrophages are not specific for DAH. They can also be seen in patients with idiopathic pulmonary fibrosis and some other disease states. And I think you guys are very well versed with the radiographic changes based on the imaging you shared. So unfortunately, treatment of SLE-related DAH is mostly based on case reports and expert opinion. There is no clinical trial data. It's hard to do clinical trials in patients who have rare manifestations of rare diseases or uncommon diseases. But we do have consensus that this is an aggressive, life-threatening manifestation, so it needs aggressive therapy. So, you guys did pulse steroids in your patients, which is usually 500, 2,000 milligram of methylprednisolone for 3 to 5 days, followed by high doses of oral steroids, which is prednisone 1 milligram per kilogram or equivalent. And then the kicker is, what second immunosuppressive treatment do you choose and how do you choose? I mean, typically when I think about a second immunosuppressing agent, especially for SLE-DAH, my first go-to is cyclophosphamide, even without the presence of kidney disease. And I will explain that in just a minute. But rituximab sequentially with cyclophosphamide can also be pursued for patients who have inadequate response to cyclophosphamide. Mycophenolate mofetil and azathioprine have been described, but I usually do not tend to use it since these patients are usually quite sick to be in the hospital and need aggressive treatment. So I'm sure you all know about the cyclophosphamide regimens that we use in lupus. I have personally not used the Cyclops regimen. I either go with the Eurolupus or the NIH regimen. I think that's just how I was trained. The NIH regimen is 0.5 to 1 gram per meter square, which is given monthly for 6 months, and then it's given quarterly. So it's a lot of cyclophosphamide with cumulative dose over time. The Euro-lupus regimen is only 500 milligrams every 2 weeks, which is done for 3 months. There is oral cyclophosphamide also, which is usually given for 3 months in lupus nephritis. But we tend to use either these two regimens. Now, the reason I go with cyclophosphamide for most of my lupus DAH patients who are sick in the hospital is because it is associated with improved survival. Now, I don't know if there is a bias, that is driving this statement, because most patients with lupus DAH that are in the hospital are again sick and land up receiving this drug because of the aggressive nature of the disease. Now, coming to the Euro-lupus nephritis trial, we know that, compared to the NIH cyclophosphamide regimen, this compared the NIH regimen to the low-dose cyclophosphamide regimen. And it was found that the Euro-lupus nephritis regimen was equally effective for short-term renal remission induction, but also long-term, which is 5 and 10-year renal preservation. And the nice thing is that the Euro-lupus regimen had fewer adverse events, because there was a lower cumulative cyclophosphamide burden with this. So fewer adverse events is basically cytopenias, as it has less bone marrow effects, as well as less neutropenias, less infection, less hemorrhagic cystitis, and some trend towards lower bladder cancer in the long run. Now, the major drawback of this study was that it was a predominantly Caucasian cohort. Now, we do have data from the ACCESS trial group, which shows that the short-term low-dose cyclophosphamide is as efficacious in a racially diverse North American population. But interestingly, in the South Asian study by Dr. Rathi and their group at PGI, they also were able to demonstrate efficacy of low-dose cyclophosphamide in inducing complete remission for class 3, 4, and 5 lupus nephritis at 6 months as compared to MMF. So there is some data from the Indian cohorts as well. So I will say that I personally prefer the Euro-lupus cyclophosphamide regimen for complex lupus patients, just because of the similar efficacy, which is demonstrated as compared to the NIH regimen, and overall less toxicity. I will still occasionally use the NIH regimen in my patients who have very aggressive disease with life-threatening organ involvement, and I will usually reserve the NIH regimen for my African-American patients in the US. Now, it's always important to remember that we talk about all this data, but unfortunately, patients who have RPGN, patients who have life-threatening disease, patients who have a creatinine more than 3, they get automatically excluded. So even if I'm telling you about all these, this data, it may not be, we don't know how it works for your sick patients who have RPGN or creatinine more than 3. So it's always important to remember that. Now, coming to rituximab, there's a lot of studies on, in terms of case reports, case series, which have used rituximab and plasmapheresis as sequential therapies. There is mixed data on both, unfortunately, so I cannot say one is better than other. Rituximab does have less toxicity as compared to cyclophosphamide, but is not as rapidly acting. So just remember that it takes a few weeks to kick in, and B-cell depletion really reaches its peak around 3rd month after infusing the rituximab. And sometimes, it's not even adequate at 3 to 6 months, and you need more time with rituximab to deplete B cells. Now, in terms of plasmapheresis, again, there is mixed data on survival with use of PLEX in SLE-DAH. Now, we know from the vasculitis studies, which is the PEXIVAS trial, there may be some role in, our ANCA vasculitis patients. But again, patients with RPGN who had vasculitis with RPGN were excluded from those studies. Now, this is a very interesting thing that has happened in the last couple of years. And I would be curious to hear from you guys actually if there is any anti-CD19 CAR T therapy coming up in India. But this is really, really great because, this German group re-engineered CAR T cells and as anti-CD19 RNA CAR T cells. And they were reinfused in patients who were young. This is 5 patients with really active lupus, scores of 18 to 16 with organ involvement, specifically lupus nephritis, myocarditis. And they had a SLE score of 8 to 16, and they were young, 18 to 24 years of age, and had failure to respond to multiple immunomodulatory therapies. So in these really resistant, active lupus patients, the group found that anti-CD19 CAR T therapy was able to successfully achieve remission, but not just remission, they were completely drug-free, including there was no need for hydroxychloroquine at the 3-month mark after treatment. And thankfully, this was well tolerated with only mild cytokine release, syndromes. Nobody had neurotoxicity or ICANS, with some fever, no infection. And we have follow-up for up to 17 months now. I know there is more happening in the US. We actually just got approved for anti-CD19 CAR T therapy for, not a trial, but a study at Allegheny Health Network, where we are looking to enroll for 1 sick patient. So I know this is taking off. I saw some case reports for anti-CD19 CAR T cell therapy in the adolescent population for lupus. So I would be curious to actually hear from you all if this has ever been discussed in India. But those were my slides and my presentation, and I would be curious if you have any questions or if you want to go back to our patients and do those questions again.
So I'll just tell you 2 questions from the chat box. I think you've already answered, but since somebody, data on combining rituximab plus cyclophosphamide in life-threatening complications like RPGN and DAH.
Yeah, so sequential rituximab with cyclophosphamide is certainly being used, especially the data is coming from the European, experience. I think Dr. Eisenberg's, is the group there. But, the thinking is that, our SLE patients have so much immune activation from activated B cells, that they are they're causing the organ damage and organ activity there. And cyclophosphamide at the dose we use may not be enough to completely suppress the B cell activation. So, the cyclophosphamide followed by specifically suppressing CD19-20 B cells using rituximab has been shown in life-threatening disease to, provide some benefit. So I will use rituximab sequentially after cyclophosphamide, like you have already done for the second patient, where, you give the cyclophosphamide for the 3 months, 6 months, whatever you decide is best. And if there is still incomplete response and activity, I will add rituximab. I will do rituximab as 1 gram, RA protocol. But sometimes, I find that there is reaccumulation of B cells after the 3-4 month mark after giving rituximab. So sometimes what I do, and I have done this for 2 patients now, I will start checking their CD19-20 levels around the 3rd month, 4th month mark. And if I see that there is repopulating B cells, then I will split the rituximab as 1 gram every 3 months. So, there is some objective data to back your decision along with the recurrence of disease. And then now we have obinutuzumab, so obinutuzumab is, as you all know, it's more potent B cell therapy, which is longer lasting. I'm actually trying to get one of my patients currently approved for obinutuzumab She has lupus with ganglionopathy and dysautonomia, which she has an incomplete response to rituximab. But it's not approved. It's not FDA approved. It's used only in certain disease states. But, one of my colleagues has been able to get it approved, for saying patient has rheumatoid arthritis. So that's my approach as well. But I don't think there's any great trial data. This is again all experience, and expert opinions.
Which protocol do you prefer for SLE DAH without RPGN? Urolupus or NIH?
So I prefer Urolupus. Like I said, I will occasionally use NIH when my patients are, African American, where we know they may have an incomplete, response to the Urolupus regimen. But I think over the last time I used an NIH protocol was actually for an African American patient who had myocarditis and lupus nephritis. So actually, I've never used NIH for DAH. So my practice has definitely kind of changed from more NIH, and I think that's because I got trained in Baltimore, to more Urolupus, because now in Pittsburgh, it's more Caucasian population, and I use more Urolupus in general.
Any possibility of an SLE ANCA overlap in patients having RPGN and DAH?
Yeah, so that's a really good question. I have been fooled before. We actually think this is all lupus, but there is definitely case reports of ANCA positive RPGN or ANCA positive glomerulonephritis in patients who have lupus. Now, the biopsy there will be very beneficial because, as we all know, lupus GN is going to show you that classic full house immunofluorescence, whereas ANCA is going to be very pauci-immune, crescentric necrotizing GN. So, the biopsy will help to differentiate. And if I am treating lupus with ANCA RPGN, I would still go with, and if kidney is the major involvement, organ involvement, I would go with rituximab. I don't think there's anything wrong in doing cyclophosphamide, but we know that rituximab works really well for ANCA GNs.
Yeah, but
based on the RAVE trial.
Yeah, rituximab will take time to act. So would you straight away go for rituximab, or would you give one cycle of cyclophosphamide upfront and then?
Yeah, so if you're talking about ANCA RPGN, I would still go with cyclophosphamide. But if you're just talking about ANCA GN, where there is no rapidly progressive GN, then I would go with rituximab. So I agree, rapidly progressive GN, I would still choose cyclophosphamide first, sequentially add, rituximab.
Would you
Now coming to
Yeah.
coming to the plex, I was going to say that, I typically tend to do 5 sessions of plex, but, it's quite all right to stop the plex after 3 or 4 sessions if the patient is improving and is coming off of mechanical ventilation.
Do you recommend to check anti-GBM or ANCA whenever you see, in all patients, whenever you see a DAH plus RPGN?
So I personally will check for them because I just feel like, sometimes we have our bias and our assumptions and there's something else going on, and anti-GBM, it can happen with, different disease states with overlaps. So we have a protocol where we tend to check ANCAs and GBMs and, cryoglobulins for most of our patients.
What is
It
the
takes
ideal-
time. Yeah.
Sorry. Yeah,
No,
you
it sometimes takes time for these, serologies to come back. So, it's absolutely like you already did, start the treatment and then back off if we need to. But I do tend to check for all those things. I also tend to get a lot of infection workup up front in my patients. We know that procalcitonin is, it has its pros and cons, but anytime I see a lupus patient with an ESR over 100, I tend to get infection workup. And it's not just one-time blood cultures. I tend to get sequential blood cultures because we know that our immunosuppressed patients don't always mount a inflammatory response, especially when they're on high doses of steroids with fevers and don't always have that leukocytosis.
What is the ideal time gap between cyclophosphamide and with rituximab? If we do decide to give both, especially in acute ANCA, which I think you've answered that already. The role of IVIG in management?
Yeah, so IVIG is actually, used, but there is no data supporting use of IVIG in DAH. I looked into it a little bit. I think IVIG may have some role when there is concomitant infection, especially if you have somebody with, high titer, dsDNA and other antibodies where it could potentially, help to eliminate some of that, pathogenic antibody there. But it's not really used commonly for DAH.
Dr. Deepti, Dr. Shri, you had questions? Deepti and Shri?
No, ma'am, I think all questions have been answered.
How to manage APLA, antiphospholipid syndrome associated with DH, because APS and SLE could lead to DH.
Yeah, so, I didn't get into this, but, recurrent DAH, is a different entity in itself. And if recurrence of DAH is happening, I think we need to think about number one, is patient really taking the treatment that is being prescribed? Now, with IV cyclophosphamide, you have that assurance that the patient is getting the medication, but are they really taking the steroids at home? Are they taking any other treatments that are given to them at home? Because compliance with meds is a big factor in my experience in terms of inadequate response. Now, the other possibility is there underlying infection that is contributing, or, is there something else going on like anti-GBM or ANCA? And then, in terms of antiphospholipid syndrome, that's a really good question because we know that antiphospholipid syndrome itself causes DAH, but indirectly antiphospholipid syndrome will also cause inherited factor deficiencies that can lead to bleeding in lupus. So, unless you do that workup, it's hard to tease out why the bleeding is ongoing. So, but the treatment is the same in my mind. You're already like the cyclophosphamide, the Plex, rituximab, they all work for APS related DAH too. I mean, the other, would be, the anticoagulation management where you need to have your hematologist on board.
What is the time gap if you're giving Plex and then rituximab? So they want to know the order, which one first, because
Yeah, so I tend to do rituximab after Plex. Like, if you're doing 3 sessions, 5 sessions of Plex, you do the rituximab after all your Plex sessions is done. Because, if you do your rituximab and then Plex, you're taking the drug right out. And even with cyclophosphamide, I try to do the cyclophosphamide first, then Plex, then cyclophosphamide, So you just have to be mindful about not doing those treatments on the same day as your Plex.
Supposing you decide to give IVIG in certain situations, the time gap between IVIG and Plex.
Yeah, so I do IVIG after Plex also because, Plex, you're basically removing whatever you're infusing.
Right.
And, most hematologists will say 24 hours,
So you finish all the cycles of Plex and then you would give IVIG, right?
Yeah, that's what I tend to do. I don't know what you guys, do or what your experience is because I just worry that the Plex is every other day. Sometimes with anti-GBM, they get Plexed every day. So then, it's not, ideal to infuse when you're not sure about the adequate treatment staying in the system.
Yeah, agree. Dr. Varsha, Dr. Sanket Shah is there if you have any questions. Any of the students, you can unmute and ask.
No, I think she's covered it so well, Dr. Tanmayee. Thank you so much.
Oh, thank you for having me. I'm glad I could answer this. This is very interesting. This is what I like to see. I know these patients are so sick, and I just feel bad that they're all young women. Just like, you have your children and your lupus is like coming in the way of life. And I don't know, I would be curious to hear if you guys have CD19 in India. But, it has really promising data for young people with really active lupus.
We do it sometimes. Just one more question is there. So you talked about pulmonary capillaritis, bland pulmonary hemorrhages, and DH. So lung biopsy is usually not possible. So just a few clinical clues like, how to differentiate clinical or radiological where you can distinguish one from the other.
So I will say this, if we have somebody with a rheumatologic disease, I think the predominant, pathophysiology is pulmonary capillaritis. Sometimes our patients are going to have a bland hemorrhage or, DAD, but I really don't think that's the leading pathophysiologic process for DH in our rheumatic disease patients. So, I really don't utilize lung biopsy either. It's just nice to know that these are the underlying pathophysiologic mechanisms. Now, if you have somebody with ARDS, ARDS can happen in lupus, but if there is an ARDS picture, I think it becomes important to rule out infections, including atypical infections and drug use and so on and so forth. So I think the underlying history can help us think in certain ways.
I had a question. You were talking about infection workup in these patients. Because of cost constraints, we sometimes cannot do a complete workup for organisms like CMV, etc. What other organisms do you suggest we work up for? And do we do a respiratory biofire? Because that is what we have an access to, but individually, it's very difficult to either do it on serology. So what would you suggest doing?
Yeah, I definitely feel like the cost constraints in India, it's easy for me to say like, hey, I want to get this whole battery of panel, and it's, cost is still an issue in the US, but these are sick people, so I feel like the more data we have, the better it is. I tend to get the respiratory panel because sometimes I'm so surprised there is adenovirus that is persistent. There are some lupus patients who are not able to clear that adenovirus or that EBV that come in with recurrent problems. So I tend to get the respiratory panel, EBV, CMV, tend to get HSV, your hepatitis B, C, HIV, all those things. And then, in fact, like blood cultures. And since COVID, we're all doing COVID, and like flu season comes and goes. So we tend to check our flu viruses. So we do tend to do, I at least tend to do quite a bit of an infection workup in my patients, especially when there is some suggestion that there could be an infection process. And again, the clues are fever, elevated ESR-CRP, which is not responding to treatment adequately.
Anybody else? Any question? Deepti, Shri, Dr. Shyam?
No, ma'am, I think ma'am answered most of our queries, and I think the questions were already asked in the chat box, most of them. It was a very nice session, ma'am. Thank you for the nice interaction and the learning points what we got.
It was
Oh,
absolutely.
you're welcome. Yeah, I'm glad you invited me because I feel like, we see so many sick people, and this was a really good discussion, good cases.
Yeah, it was an excellent, and the flow was so good, the way you went step by step, the interaction with the students, and then later on how step by step you, through the slides you went through and the questions you answered. It was a great pleasure to interact with you today. I'm really looking forward to more sessions with you. And we had about 33 attendees today, which is good for the first session. I'm sure it will double up by next time. And whenever you do come to India, do let us know. We shall meet up. So on behalf of the Department of Clinical Immunology and Rheumatology, Bharati Vidyapeeth Medical College and Hospital, Pune, and my colleagues, myself, Dr. Kavita Krishna, Dr. Varsha Bhatt, and all my students, Dr. Deepti, Dr. Shri. So Dr. Lata Bichile ma'am is also saying, well done, Tanmayee. So I think we all are proud of you. Yeah, thank you so much for being here
That's
today.
great. I mean, I should say this, kudos to you for keeping this so organized, because I was getting a little nervous about, but your students, did a great job with the cases, and they sent me the info beforehand. So it was very helpful for me to present. And kudos to you for reaching out to me, because I'm not very good about being proactive with some of these things. So thank you so much.
It was fantastic. So everybody have a great evening and a great weekend. Thank you, Dr. Tanmayee, and everybody for joining us today. Yeah. Good night.
Thank you.
Thank
Have
you.
a
Good
good
night.
weekend.
Bye-bye.
Bye.
Yeah. Good day to you, Tanmayee. Yeah. Bye.
Yeah. Bye-bye.
Bye-bye. Take care.